As Dr. Taylor mentioned, I started my career more as a scientist actually, and I was working in the lab, and I decided that I like spending my day with people more than test tubes, and so I made kind of the switch, and now I'm providing clinical care. And when I came to UCLA, I actually took it upon myself to learn more about fibromyalgia. And I interface with people like Jeannie Melvin, who I see in the audience, and Melanie Cohen, who I see in the audience, and Dr. Sidoroff, and others who care and really themselves care a lot about fibromyalgia and patients who suffer from the condition. And I think it's a condition that's very frustrating at first to physicians who don't know how to approach it, but once you grow to understand it, you find a much more satisfying experience of providing care to fibromyalgia patients, both for yourself and for the patient. I'm going to start with a little bit of history, and I think this will explain some of the confusion that exists today about fibromyalgia. In 1816, Dr. Balfour described a fibrous thickening of muscles and connective tissues in patients with rheumatic conditions. So he basically took patients who suffered from lupus and rheumatoid arthritis and dissected them after death and found this more fibrous tissue that he described there. From this, the term fibrositis originated. That was first used in 1904. And this was a pathologic, not a clinical entity. So this always referred to the pathological finding, like when you look at the inside tissues of patients with what we call connective tissue diseases or autoimmune diseases today, they saw this fibrous tissue that they felt was abnormal. People extrapolated this to people with all sorts of rheumatic diseases, and when fibromyalgia was initially thought to be an autoimmune disease in the same way that lupus and rheumatoid arthritis is, the assumption was that that same kind of fibrous connective tissue and inflammation in connective tissues, and the tissues kind of hold the body together, is the reason for fibromyalgia, but today we know that to be false. That's not true. Okay? There's still that notion, though, and if you look at the older literature, that fibromyalgia has to do with inflammation in connective tissues. And I want to stress that, as Dr. Taylor introduced the topic earlier, now we know fibromyalgia to be a condition of the central nervous system and of the nervous system. That's where the essence of the pathology lies. It's not a disease of the tissues in the arms and the legs, as it was originally thought. The term fibromyalgia was first used in this article in 1981, and it described the clinical entity based on a study of 50 patients. And this is where the classic tender points come from. So what they did is they went and they kind of pressed on people who said they had a lot of pain, and they found over here the percentages of how many people reported pain at these sites. And they took the top sites, and they said that people who have fibromyalgia tend to hurt at these sites. For a long time, the clinical criteria for diagnosing fibromyalgia relied on the presence of these tender points, but as Dr. Taylor said again, this was recently tossed out, and this is no longer necessary to make the diagnosis of fibromyalgia. In this original article, they also already noted what seems to help or make fibromyalgia worse. And a lot of these things still hold true today. Aggravating factors: cold or humid weather, fatigue, sedentary state, anxiety, and too much activity. Relieving factors: hot showers, being active, warm, dry weather, and massage. These are the old criterias, and these are the new criterias put together by the American College of Rheumatology for the diagnosis. And as you can see, they're not very simple to apply. You have to basically read through that whole paragraph there to kind of figure out how to diagnose fibromyalgia, but I'll boil it down for you. If you hurt in many sites, if you have the signs of non-restorative sleep, if you've been experiencing these for more than 3 months, and if no other explanation for these symptoms was found, then you have fibromyalgia. And that's what it basically boils down to. Now, when we look at this more closely, you'll notice that there's a long list of body parts. Let me see, over here. And basically, if you hurt in many of these sites and you have even just mild signs of non-restorative sleep, you can make the diagnosis of fibromyalgia. But if you hurt in just a few of these sites, but you have very prominent signs of non-restorative sleep, okay, then you can still make the diagnosis of fibromyalgia. There's a combination of recognition that fibromyalgia is a sleep disorder and a pain disorder, and one can kind of, if you have more of one, it's okay to have less of the other, and if you have more of the other, less of one, but they tend to go together. Fibromyalgia affects about 5 million Americans, 3.4% of women and 0.5% of men, and about 2% of the general population have fibromyalgia. This is epidemiologic studies that have been done, and the percentages all over here fall right around 2%. These are studies from around the world, and the percentages in general are around 2% all over the world in developing nations. What's the cost of fibromyalgia? Well, a study was done, and a patient with severe fibromyalgia costs about $2,300 for a 3-month period to the healthcare system. Now, with the new healthcare laws coming into effect, Obamacare, and the emphasis on reducing the spending of the government on healthcare, this is very important. The indirect cost of fibromyalgia, so this is time lost from work, productivity lost as a member of society, are very significant. A patient with severe fibromyalgia, if you combine these, basically the disease costs society about $10,000 in a 3-month period, or $30,000 a year on average. So this is something that we as a society need to address and need to do a better job of addressing. And until now, there's been a very strong deficiency in addressing this issue. And as Dr. Taylor said, my rheumatologist doesn't believe in fibromyalgia. Well, that's just covering your eyes and ignoring the problem. And if we had more effective ways of addressing this syndrome, we can probably reduce this cost. What is the pathology? Fibromyalgia is an acquired deficiency of descending pain inhibitory mechanisms that leads to neuroendocrine dysregulation. There's altered perception of pain, sleep disorder, and fatigue. And I'm going to talk about this in more detail. Patients perceive muscle fatigue and weakness, but objective testing of strength are normal. There's no histologic abnormality in the painful body parts. This means that if you take a biopsy of a body part that hurts for a patient with fibromyalgia, if the pain is there because of fibromyalgia and not because they have osteoarthritis or sciatica or something else, you're not going to find anything wrong with the tissue that you biopsied. Okay? It's going to look normal when you look at it under a microscope. Same stimulus, more pain. And the tool that we have now to demonstrate where the pathology does lie is the functional MRI. And the functional MRI is able to tell us it kind of shows what parts of the brain are lighting up in response to external stimuli. It gives us a window into how the brain works. And this has really revolutionized the field of fibromyalgia. Now, is fibromyalgia unique to people? It's not. Okay. Rats exposed to 30 minutes of loud, sudden noises each day for 4 days develop fibromyalgia. Okay. There's also a rat model for the metabolic syndrome, which are rats that are overweight and tend to have diabetes and high blood pressure, and they also have a lower tolerance of pain. And rats treated with reserpine, which depletes some of the neurological transmitters in the brain, also develop fibromyalgia. So we know that fibromyalgia is not unique to people. It is a biologic process, and you can find it in other mammals as well. This is the one study I'll talk about a little more in depth, and then we'll get to the broader concepts. And this just illustrates how functional MRI is used. For this study, they took people and they pressed with a rubber probe on their thumb with a known pressure. You'll notice that patients who did not have fibromyalgia were able to tolerate a lot more pressure before reporting pain than patients who have fibromyalgia. So if you press with a probe For a fibromyalgia patient with a certain amount of pressure, they will report pain, but the same amount of pressure does not elicit pain in a person without fibromyalgia. When they did this with the patient inside a functional MRI machine, what they saw was that the rostral anterior cingulate cortex, which is, I'm going to talk about this a little more later too, which sends an inhibitory signal to the pain centers of the brain, lit up in both the fibromyalgia and the healthy controls, but the connection between this nucleus and the pain sensing pathways was defective in the fibromyalgia patients. So it means that the natural anesthetic capability of the brain could not be accessed by the fibromyalgia patient. Healthy individuals report 3 out of 10 pain at water temperature of 1 to 7 degrees Celsius, but fibromyalgia patients can only tolerate a temperature of 13 degrees Celsius. So cold seems to induce pain at a much higher temperature in fibromyalgia patients than in controls. Expectation of pain relief occurs only at the level of the brain in fibromyalgia patients, not at the level of the spinal cord, and the inhibitory spinal signals remain deficient. These are the pain pathways, and what I want you to get out of this is that they're complicated. There'll be a quiz on this at the end. Okay, everybody write this down, okay? One of them looks kind of like a sunflower, the other like a daisy. Okay, you can remember that too. What I want to get at is that pain is complicated, and a lot of things modulate pain. And the reason that we as physicians and Western medicine have been having so much trouble treating pain effectively is because of how complicated this is. Over here you have the sensation of pain, and these are all the different things and factors going on inside your body that affect ultimately how the pain is experienced and if the pain is sensed or not sensed. And you all know that you've been in different situations that can illustrate this. If you were in the middle of hiking, a long hike, and you got a little scratch from a thorn while you're walking, you may not even notice it. You'll just keep walking. You have your adrenaline running. You're enjoying the sunshine, the day, the fresh air, the friend that's hiking with you. And you didn't even notice that thorn brush up against you and scratch you. You only notice it when you get home. But if you were sitting watching TV and you were very relaxed and somebody came up with a thorn to you, showed you the thorn, and then scratched your leg, you would feel that. That would hurt, you know. So why is that? Why is it that the same scratch by the same thorn hurt in one situation and didn't hurt in another situation? And this is the answer. This is another schematic diagram, and this one kind of looks like the New York subway system, doesn't it? Okay. So again, pain is complicated. The way I like to understand it is this. We'll start with the human brain, and this is my rendition of the human brain. Okay? And we're going to shrink it up over here and attach a spinal cord to it, and that's kind of the main cable connecting the brain to the rest of the body. And then there's a nerve that goes to the hand, and this is a nerve specializing in conducting pain signals. And many of my patients, you'll recognize these drawings that I've done for you in the office. If you get a splinter stuck in your hand, what happens is that the pain nerve lights up and sends a strong pain signal to the spinal cord. As soon as the signal hits the spinal cord, the signal is suppressed. The spinal cord immediately kicks into action anesthetic pathways that suppress this pain so that only a small fraction of the original signal over here ends up making it to the more primitive parts of the brain. Over here, once the signal hits the brain, these other areas with neurons in the brain kick into action, and they send another suppressive signal so that the part of you that is conscious and aware of the pain ultimately receives only a tiny fraction of the original painful signal. This is the healthy state. And this is another way to illustrate it. A painful stimulus hits the spinal cord, gets suppressed, hits the brain, gets suppressed again, and then you are made aware of this. So we're all walking around with natural anesthetics in us. We're all walking around as if we're actually on very strong painkillers. That is until we have fibromyalgia. And in fibromyalgia, all of these inhibitory pathways are not there. The pathways in the spine are completely non-existent, and this has been shown through study of spinal reflexes in patients with fibromyalgia. This is something that's not even happening at the level of the brain and is beyond the control of the brain. And at the level of the brain, the signals that are supposed to inhibit pain are not there, so that by the time the pain signal hits your brain, it hits it with full force. Doc, why me? Why do people get fibromyalgia? How do they end up with this condition? Why does this happen? Well, we know that trauma is a risk factor. We know that people who've been exposed to sexual abuse, physical assault, end up with fibromyalgia. Something about the traumatic experience, the acute traumatic experience, changes the chemistry and the makeup of the brain, takes off the brakes off of those anesthetics, and now you start to hurt. We know that exposure to pain in early age can also set this off. This is a study that was done with infants hospitalized at the neonatal ICU unit where they got a lot of painful procedures, unfortunately performed on them. And these children, as they grow up hypersensitive to pain. The natural pain inhibitory pathways are not as mature, they don't develop the same way, and these people end up with fibromyalgia. They end up more sensitive to pain. The same stimulus that in a healthy individual would not elicit pain, in somebody that experienced a lot of pain in early childhood, physical pain, now does not, now they feel it much more prominently. We know that these are the triggers or the causal agents of fibromyalgia. Post-infectious, and a lot of these we don't know the exact mechanism. We don't know how they achieve this. And we don't know what's really in common with all of these, but Dr. Taylor alluded to some clues between the immune system, the endocrine system, and the neurological system, and that's probably where the link exists. But after some infections, fibromyalgia can start. Psychological trauma, I alluded to. Obesity, sleep disorders, depression, and chronic somatic pain. Chronic somatic pain meaning pain for another reason, not from fibromyalgia. So if you're walking around with pain from sciatica, from spinal stenosis, from osteoarthritis, bombarding the brain with chronic daily pain from another reason will destroy the body's ability to reduce pain. And this is counterintuitive. You think that our bodies should be programmed to be able to ignore pain if it's there for a long time and we're not doing anything about it. But the body actually tries to call attention to the pain and does not allow you to ignore pain. And it does this by magnifying the pain and generalizing the pain until your whole body hurts. The genetics. There have been some genes associated with fibromyalgia, but the genetic study of fibromyalgia is still very early in its studies, and we don't have a good sense of the genetics. So at this point, it's also hard to tease out environment and genes because a lot of times within the same family, when multiple people have fibromyalgia, they're also exposed to the same environmental stressors. So if somebody grows up in poverty in a poor neighborhood where there's more violence and more stress, then in the family you may see more fibromyalgia. That doesn't necessarily mean that everybody in the family has a gene for fibromyalgia. It could be that they're exposed to the same environmental triggers. But that being said, we do know it does look like genes do play some role, and this is still being studied. So all of these factors that I mentioned earlier, when they occur in an individual that's predisposed, they ultimately cause fibromyalgia. The anesthetic mechanisms of the brain and the nervous system are removed, and we're now in a state of chronic pain. I mentioned obesity, and there was a study done where 43 patients with obesity were randomized to treatment of fibromyalgia with weight loss or without weight loss, and the outcome was improved in patients which reduced their weight and were in the weight loss program. We know that obesity leads to also more pro-inflammatory cytokines that Dr. Taylor spoke about earlier. So excess fat tissue leads to more inflammation and also leads to more pain. And there is probably some connection there between the immune system, inflammation, pain, and the nervous system. But we're still very we still don't have all the pieces of the puzzle to put it all together. Obesity can cause fibromyalgia by these three mechanisms. As I mentioned, inflammatory cytokines, sleep apnea, which is more common, causing the sleep disturbances, and painful conditions such as osteoarthritis. The pain of fibromyalgia is due to a deficit of endogenous pain inhibitory systems. It's not found in patients with just regular old chronic low back pain. And treatments proposed for fibromyalgia patients should aim at stimulating the activity of those endogenous systems. And this is now the introduction that I have for the treatments, because we need to build up those natural pain-killing systems within our bodies. Now, before we diagnose fibromyalgia, we have to make sure that we're not accidentally missing something else. Vitamin D deficiency can cause a person to be achy. Certain medications can cause side effects of muscle aches and bone pains, endocrine disorders, and autoimmune diseases. The treatment begins with explaining to the patient what fibromyalgia is, as we're doing over here today. What I like to tell my patients about it is that you're not sick, your body is just made differently. Fibromyalgia is not a disease, it's a state of being. Okay? And in that sense, it is somewhat like obesity, I think. When somebody is overweight, we don't like to think of it as a disease. It's not the same, it's not like saying they have a pneumonia, but they're just in an unhealthy state of being, and we need to work to try to make things better. The brain is hypersensitive to pain. For the fibromyalgia patient, pain does not equal injury. And this is really important. Okay? Pain does not equal injury. We know that our body is programmed that when you sense pain in a body part, you assume that that body part is injured, that there's something wrong with that body part. For the person with fibromyalgia, they will get sensations of pain from simple pressures that are normal to be applied to joints, from stretches of muscles and tendons, which are within the normal limits of stretches experienced in everyday life. Bowel function as we digest and our digestive system works. There are sensations within the bowels, but the thing in fibromyalgia is that all these sensations that people without fibromyalgia are able to ignore and are they are anesthetized to by their own immune system. The fibromyalgia now experiences all of these sensations, are aware of all these sensations, and are aware of all these sensations as pain. They sense these as pain. So a stretch is not a stretch is pain. Pressure is not pressure, it's pain. Cold water is not just cold, it's painful. Everything becomes painful. But what it's important to understand is that that pain doesn't mean that there's something wrong with that body part. And this is where the rheumatologist is helpful, because your doctor's job is to be able to differentiate between pain due to injury and other causes and pain due to the hypersensitivity of fibromyalgia. I tell patients that we do not have drugs that can completely take away your pain, and we have to cope with the pain in other ways. Okay? You will get better, but it will take work, and the solution is not in a pill. We do not have a pill that makes the fibromyalgia pain better. This is a little extreme, but the approach is almost in the same way as a stroke. And I think of fibromyalgia 20 years ago in the United States is kind of like treating stroke victims 200 years ago in the United States. When somebody had a stroke and a part of their brain dies and stops functioning, and now they can't move their arm or they can't move their leg because the nerves to that body part are no longer there. If you examine that arm or that leg, you will find nothing wrong with it. The arm and the leg is fine. The reason the patient can't move the arm or the leg is because the part of the brain that controls the arm of the leg is malfunctioning. You can imagine doctors hundreds of years ago looking at the arms and legs of people with stroke and not understanding why it is that they can't move. And they might tell the patient, even it's all in your head, right? Why can't you move your arm or your leg? Your muscles are fine there, your bones are fine there, you should be able to move it. Well, they're looking in the wrong place. The problem was that they had a stroke in the brain, and that's why they can't move the arm or the leg. In fibromyalgia too, the pain is sensed all over the body. The pain is sensed in the stomach, in the arms, in the legs, in the tendons, in the muscles, in the tissue. But the essence of the pathology, the problem is not in those body parts that are hurting. The problem is in the brain and the central nervous system. And that's what needs treatment. It's important to treat and diagnose psychiatric disorders such as depression, and we know that if a person with fibromyalgia suffers clinical depression, the treatments for fibromyalgia will not be very effective until the depression is treated. We need to address psychological trauma, and this is where it's important as the physician to ask about psychological trauma. It's important for the patient to recognize that psychological trauma, such as abuse in childhood or in adulthood, or a traumatic event such as a car accident, can impact the way that the brain works and can impact the fibromyalgia, and addressing those issues with a trained practitioner can help. We need to treat somatic chronic pain. So if a person has pain for other reasons, that needs to be addressed. And we need to treat sleep disorders. And we refer for sleep testing, we teach sleep hygiene, we refer to sleep therapy. We know that when you don't sleep, you hurt more. And we know that when you do get good, restful sleep, you hurt less. Aquatic physical therapy has been shown to be beneficial. And we like to refer to that. The patients with fibromyalgia seem to do better with exercising in the water than they do with exercising on land. And this is interesting, behavioral extinction training. What this means is not focusing on the pain. You have to, in order to build up the natural mechanisms built into your nervous system that reduce pain, you have to stop training your brain to focus on pain and find ways to distract yourself away from the pain and build up the systems that were there at some point in your life that suppressed pain. Pharmacologic treatment is cautiously recommended, and point out that amitriptyline, but you can really put pretty much any medication that's advertised for fibromyalgia, and showed a 14% improvement of fatigue, 9% improvement in trigger points, 26% improvement in pain, 23% improvement in sleep, and 18% improvement in well-being. And this is pretty consistent among all the drugs for fibromyalgia treatment, about a 20 to 25% improvement of pain. What does this mean? This means that if you have fibromyalgia and you have 10 out of 10 pain, and you take Cymbalta or Lyrica or Savella, what you can expect, according to the studies, is a 20% reduction in pain, which means your pain level will go from a 10 out of 10 to an 8 out of 10. You can't expect to be feeling perfect like the ladies on the commercials on TV, right? Where they take their pill and then they're smiling and painting and enjoying life. The pills that we have available are far from perfect. They have some side effects. They do help, but they're not a cure, and they're more of a crutch than a true treatment. I mean, they just help a little bit. That's what you do. Now, for the individual patient here and there, the pills are very effective. But for most people, the response is moderate. This is also showing a reduction. This is the placebo group in fibromyalgia, and this is the treatment group. And you had a mean change of pain from baseline. This is for Cymbalta, of 2.5 points on the visual analog scale. That means a 25% improvement. And this is in the official trial that the FDA did to approve Cymbalta for the treatment of fibromyalgia. They noted that patients went down on average by 2.5 out of 10 points in their pain. So these are the drugs that we have. Avoid narcotics. Avoid narcotics, avoid narcotics, but sometimes you have no choice, right? So I'm sure that you've heard from your doctors that you have to be careful with Vicodin and codeine and Percocet and oxycodone. All of these medications do provide short-term relief of pain, but ultimately they cause more problems than they solve for many patients. The reason is that when you use these medications, your body actually upregulates its sensitivity to pain in order to compensate for the anesthetic effect of the medication. And it can make, in the long term, your fibromyalgia worse. Okay, so it increases the sensitivity to pain in the long term. That being said, we know that there are patients that are very distressed and nothing else works, and the patient is miserable, and we know that narcotics do ultimately help, so we do use them. But we always use them grinding our teeth a little bit and not being so happy about having to use them. It's just that this is kind of the best that we have. I think that the best use of narcotic analgesics is for short-term flares if a patient is absolutely miserable. It's to help the patient just get things under control, put their lives together, get things back on track. But if at all possible, you want to avoid long-term continuous use of the strong painkillers. Acupuncture can help, but the results are mixed. Massage you have to be careful about, because strong massage, vigorous massage is usually not helpful. For the masseuse that knows what they're doing, perhaps and they're very light with their touch, that can be helpful for patients with mild fibromyalgia. I think in cases of severe fibromyalgia, massage is usually not helpful, and strenuous exercise is not helpful either. You have to exercise, but in moderation. So the bottom line is healthy lifestyle. Avoid fatty meats, eat your veggies, get daily exercise. This seminar is here to really empower all of you to be your own doctors, to be your own best doctors. And it's our job as your doctors to walk the journey with you and to guide you and to help you where we can. But ultimately, it's up to you to do the things that improve overall health and well-being in your life. And we hope that the information that we give you today will help you do that. Thank you.